morning. Good morning, ladies and gentlemen. It's a pleasure for me to be here at this platform of DMA. And my talk is going to be about recurrent pregnancy loss. What are the controversies and consensus about recurrent pregnancy loss?
अरे यार कहाँ से लूँ?
I think we are done now. That's my topic, recurrent pregnancy loss. What are controversies and consensus? Pregnancy loss is a significant negative life event. All of us know any woman who loses a pregnancy, it has a lot of emotional upheaval, lot of negative feeling in the lifetime, and we are all worried about that. And there is an increasing burden of pregnancy loss in India. When you look at it, 2015, it was almost 9.8%. In 2021, it has increased to 11.9%. So the pregnancy loss is also increasing in Indian population. A miscarriage is defined as a pregnancy which results in death or expulsion of embryo before 20 weeks. 10 to 15% of pregnancy result in a spontaneous miscarriage. We have to remember that spontaneous miscarriage is 10 to 15%, and recurrent miscarriage affect almost 1 to 5% of the pregnant women. The definition of recurrent pregnancy loss, there have been some controversies. RCOG say 3 pregnancy losses, while ASHRAE and ASRM say 2 or more clinical pregnancy losses are defined as recurrent pregnancy loss. Ectopic pregnancies and molar pregnancies are not included in this definition. When you talk of pregnancy loss, we have to talk of pregnancy loss excluding molar pregnancies and ectopic pregnancies. It is estimated that less than 5% of women will experience 2 consecutive miscarriages, and 1% will experience more than 3 miscarriages. So recurrent pregnancy has a significant emotional impact on women and their partners. That is the whole thing. Basically, that is a lot of emotional impact on the woman and the partner. This is the etiology of recurrent pregnancy loss. If you look at the chart, almost 40 to 50% remain unexplained, including non-APS and thrombophilia. So genetic factors, anatomical factor, autoimmune infection, endocrine factor constitute rest of the 60%, 40 to 50% remain unexplained. And the established causes include uterine anomaly, antiphospholipid syndrome, hormonal and metabolic disorder, and other etiologies which have been proposed but still considered controversial, like chronic endometritis, inherited thrombophilia, luteal phase deficiency, and high sperm DNA fragmentation. These are still controversial, but almost half of the cases remain unexplained. And unexplained, there may be some immunological causes like increased TH1 T2 ratio, increased T70 to TRAC ratio, increased cytotoxic antibodies, absence of maternal blocking antibodies. These are all the immunological factors which might be the reason which can explain the unexplained recurrent pregnancy loss. And no apparent causative factor is identified. But you have to remember, when you are counseling a patient with recurrent pregnancy loss, the chance of a future successful pregnancy can exceed 50 to 60%, depending on maternal age and parity. Any woman who has undergone 2 or 3 losses can still have a 50 to 60% chance of conceiving in future. And evaluation and treatment of recurrent pregnancy loss is as per the practice of Committee Opinion of American Society of American Reproductive Medicine, published in 2012. When to start investigation, when should start full workup after 2 or 3 miscarriages has long been debated. Now, for years it was recommended to wait for 3 miscarriages. However, the results of recent systemic reviews say you can start investigating after 2 losses. And in some cases, you can even start earlier, when the fetal cardiac activity was identified prior to a loss, or when the woman is older than 35 years, or woman is having difficulty in conceiving with history of infertility. You can start investigating even earlier than 2 losses. Screening for antiphospholipid antibodies, should we screen all patients for antiphospholipid antibodies? Yes, that is the most critical cause of recurrent pregnancy loss, which is well accepted and evidence-based. 5 to 15% of women with recurrent pregnancy loss have significant antiphospholipid antibodies, compared to only 2 to 5% in an unselected population. These are the different criteria how you define antiphospholipid syndrome. You must have one clinical criteria written on the left side and one laboratory criteria. You have to measure the lupus anticardiolipin antibodies, lupus anticoagulant, and anti-beta-2 glycoprotein. And you have to screen this lupus anticoagulant and anticardiolipin antibodies, both IgG and IgM, after 2 pregnancy losses, and you should repeat it after at least after 12 weeks again. What is the level? Screening for RPL for hereditary thrombophilia? No, we don't like to screen for hereditary thrombophilia, which include this protein S, protein C deficiency, antithrombin deficiency, and factor V mutant. These are the inherited thrombophilia. Generally, we should not screen for the hereditary thrombophilia. It is only recommended if a personal or strong family history of thrombosis or thrombophilia is there. Can we investigate for congenital uterine anomalies? It is preferred to evaluate for congenital uterine anomalies by transvaginal 3D ultrasound, sonography. MRI is not recommended, and in cases of some because of fibroid and endometrial polyp, cystoscopy is considered the gold standard. Shall we investigate for thyroid function, thyroid dysfunction? Yes, thyroid screening.